Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to give a brief presentation on middle meningeal artery embolization as a standalone management modality for a subset of subdural hematomas, which is a non-acute subdural hematoma. It's expected in the United States that by 2023, surgical evacuation for non-acute subdural hematoma will be the most common cranial neurosurgical procedure. We know from the literature that there are three layers of dura: the preosteal layer, the meningeal layer, and the dural border cell layer, in which the chronic subdural hematoma develops and expands. So it's actually an interdural hematoma and not a subdural hematoma. The pathogenesis of subdural hematoma includes bleeding, fibrin deposition, fibrinolysis, a sort of inflammation with neomembranes formation, and the neoangiogenesis, and so on. So the management modalities are based on this pathogenesis. We can do surgery, endovascular embolization, and the multiple drugs have been studied with the strongest evidence belongs to steroids. So from the older literature, we know that usually the source of bleeding is from bridging veins. But if bridging vein is a bleeding source, the hematoma should reach the parasagittal area where bridging veins are most prominent. But if you look at the coronal cuts, the hematoma rarely extends to the parasagittal area. It's usually expanding over the convex surface of the hemisphere. So MMA, middle meningeal artery, is gaining an increasing role in the development, or at least in the maintenance, of non-acute subdural hematomas. And there is some evidence for this theory, which includes enlarged middle meningeal artery on the ipsilateral side of the hematoma in comparison to the normal side. Also, progressively enlarging middle meningeal artery with progression of the subdural hematoma. And also the presence of capillary blush, or what's called cotton wool-like staining of the dura or the distal middle meningeal artery in cases of non-acute subdural hematomas. Also, from our practice, we know that any artery supplying pathology is enlarged. So the middle meningeal artery will be enlarged if it is supplying an AVM, a dural fistula, a meningioma, and also if it is supplying a chronic subdural hematoma. And this blush is in the membrane of the hematoma. And this is a normal external carotid artery. So the enlargement is an evidence for supply. So there is a balance between rebleeding and hematoma expansion on one side and hematoma absorption on the other side. And our rule is to stop the circle by embolization to prevent rebleeding, giving a chance for hematoma absorption. So it's a minimally invasive approach. It can be done under local anesthesia. No need to stop antithrombotics, and no need for post-operative bed rest, which is advised by some neurosurgeons. It can be done as a standalone treatment, like in our cases. It can be done as an adjunct to surgery, and it can be done in recurrent or refractory subdural hematomas, which recur for more than one time. Also, from the literature, we know that all surgical techniques have complications up to 10% of cases, and has mortality, and recurrence or reoperation rate of up to 28%. So at the end of 2024, 3 randomized trials were published in November 2024, and 2 of these trials have shown reduced treatment failure, which means reduced risk of reoperation, recurrence, or hematoma progression with embolization when it is added to neurosurgical evacuation. The precautions before embolization is to protect the facial nerve by going beyond the petrous branches of middle meningeal artery, and by avoiding blindness by going beyond the orbital or ophthalmic branches of middle meningeal artery. Case presentation. This patient had a chronic subdural hematoma, which may look small, but the mass effect is more than 1 centimeter. 5 days after embolization, the hematoma is non-surgical. 13 days after embolization, the hematoma is about to disappear. This is selective catheterization of the middle meningeal artery with cotton wool-like appearance in the dura, pre and post external carotid artery angiogram. This is middle meningeal artery, and this is the residual stem of the middle meningeal artery post-embolization. In all of our cases, we used BVA particles, 150 to 350 micrometers. Another case, preoperative. Only 6 days after embolization, the hematoma is non-surgical. After 12 days, it's about to resolve. Total resolution in less than 1 month. Again, external carotid artery angiogram, there is a significant blush in the membrane of the hematoma. This case was aborted. This patient had bilateral subdural hematomas. The case was aborted because there was total ICA occlusion on one side and dangerous anastomosis between external carotid and the internal carotid arteries, and this endangers vision and very tortuous vascularity on the contralateral side. So this patient, we didn't embolize. We just did diagnostic angiography. This is a refractory case. This patient was operated twice, and after each operation, the collection recurs again. So there is bilateral subdural collections. Only 13 days after embolization, it is non-surgical and total resolution in less than 1 month. This is selective catheterization of middle meningeal artery on left side, also pre and post-operative external carotid artery angiogram, selective embolization of MMA on the right side, and another case of bilateral subacute and chronic subdural hematomas, pre-operative, only 9 days after embolization, about 40 days after embolization, and the total resolution in about 4 months. Again, selective embolization of the middle meningeal artery, pre and post ECA angiograms, also on the left side. So we did bilateral embolization, and this is a failure case. This patient was 25 years old. He was a pharmacist with unilateral hematoma, and he asked for a minimally invasive approach. So we did bilateral embolization. After 2 days, there was a progressive mass effect. After 13 days, there is progression. So this patient underwent per whole craniostomy, and this is 2 weeks follow-up, and with no recurrence at 5 months of follow-up. So in conclusion, middle meningeal artery as a source for subdural hematomas and as a mean for management is gaining increasing interest, and further trials are needed to compare different embolic materials, to compare standalone management and adjuvant therapy, and to evaluate other parameters like the duration for hematoma resolution. So if you are interested in chronic subdural hematomas, you can review this playlist on YouTube. It includes 10 lectures about chronic subdural hematomas with 2 operative videos, 1 for surgery and 1 for embolization. Thank you very much.